good afternoon, and welcome to this webinar about the most challenging cases in pediatric oncology. This is brought to you by the ERN PICAN Young Therapy Initiative. I am very pleased to welcome our young investigator who will be presenting today's case. Her name is Morgane Cleirec. She is a pediatric oncologist working at the University Hospital of Nantes in France. She has a special interest in sarcomas. She also takes part in some groups of the French Society Oncology and Hematology. Welcome, Morgane. I am also very pleased to welcome our expert for today, Dr. Hans Merks. Dr. Merks is currently a principal investigator at the Prinses Maxima Center for Pediatric Oncology in Utrecht in the Netherlands, and he is also a chair of the European Pediatric Soft Tissue Sarcoma Study Group. Moreover, Dr. Merks is also a deputy chair of the Euro-Ewing Consortium Executive Committee and a co-investigator of the European Frontline and Relapsed Rhabdomyosarcoma study that is enrolling patients until 2027. Dr. Hans, we are very honored to have you here today as an expert to comment on this case. So today's webinar is called Sussex History of a Relapsing Rhabdomyosarcoma, the Importance of Complete Local Treatment. Let me just remind the attendees, please write your questions in the question box and we will discuss them later after the presentation. And now, without further ado, please, Morgane, the audience is yours.
Thank you. Hi, everybody. I'm happy to present my case report, my success story of relapsing alveolar rhabdomyosarcoma. Next slide, please. I have nothing to declare. So my story begins July 2012 and concerns a 15-month-old baby girl. The parents of the child observed a thoracic mass located on the right side of the chest, as you can see on the picture. And the child was doing very well and had normal activities for its age. Next slide, please. So first of all, I'll start with a question for you. And my question is, at this point, which imaging would you prescribe to help the diagnosis for this baby? 4 answers: US, MRI, CT, or PET-CT. There are maybe many answers. Okay, thank you for having answered the question. First, a good thing to see is that most of you answered MRI, which is an important imaging. I'll come back to this later. The first exam to prescribe could be ultrasound, because it's a child and it's an easy exam, and sometimes it helps. Then we can prescribe CT to help, and CT may be considered because it's easy to obtain and quickly done and help the diagnosis. But MRI is the most precise imaging for local exam of the tumor. And the principal disadvantage in this case could be that the child is 15 months old, so it's an exam that has to be done under general anesthesia, so it's a bit harder to obtain. And PET-CT would be considered later. Next slide, please. So we performed CT and MRI, and they both show a soft tissue mass developed in the posterolateral chest wall right muscle with a long axis of almost 4 centimeters. You can see in the pictures. On the bottom is the CT and the MRI. Next slide, please. A surgical biopsy was performed showing a poorly differentiated malignant tumor process with multiple images of mitosis. The immunohistochemical study showed clear and intense positivity with antidesmin and MIF4 antibodies, which almost marks all the tumor cells. All these elements were in favor of an alveolar rhabdomyosarcoma, as you can see on the picture. Next slide, please. Second question for you. Which specific fusion has to be searched at this point in this case? So you have 4 choices and there's only one right answer. Okay, my question was maybe too easy or you're too good. So the right answer was the one you chose. So the PAC3 FOXO1 transcript fusion, which is specific for alveolar rhabdomyosarcoma, has to be searched. Next slide, please. And it was positive for our patient. So it's an alveolar rhabdomyosarcoma with fusion positive. Next slide, please. An assessment of tumor extension was performed, including an abdominal ultrasound, PET-CT, a bone marrow aspiration, and bone marrow biopsy. And all these exams were negative in favor of a localized disease, fusion positive. Next slide, please. So the protocol at this time was the RMS 2005 protocol, and she was included in this protocol in the arm MH, high risk MG, because of the pathology, the alveolar with the fusion. So it had to be treated according to the MG of this protocol. As a reminder, the randomization for this protocol was the interest of adding doxorubicin to ifosfamide, vincristine, and actinomycin in this patient. So the protocol was 4 courses of ifosfamide, vincristine, actinomycin, and doxorubicin, and 5 courses of ifosfamide, vincristine, and actinomycin, and a surgery and radiotherapy. Next slide, please. After 4 courses of chemotherapy, the tumor has reduced with 65% reduction, as you can see on the big pictures. The little pictures showing the diagnosis, so you can compare both. So it was a correct reduction of tumor volume. Next slide, please. After 4 cycles, we performed the surgery consisting of a tumor resection with microscopically incomplete margins, but it was not possible to do better, and she couldn't have a second surgery. So complementary radiotherapy was done on the tumor area, and on the pictures you can see the areas of radiotherapy, and the dose was 45 grays. Next slide, please. At the end after completion of the 9 cycles, 9 courses of chemotherapy, surgery, and radiotherapy, was the question of the maintenance therapy in this protocol. And patients was randomized whether with maintenance or without maintenance, consisting of 6 cycles of vinorelbine and cyclophosphamide. She was randomized in the arm with maintenance therapy and received complete her treatment in September 2013. Next slide, please. Unfortunately, in February 2014, she relapsed, and it was a non-metastatic relapse. On the pictures of the left side of the screen, you can see the the radiotherapy area of the first disease. And as you might see, the second disease was not in the area of radiotherapy. So we considered it as a metastatic relapse. It was located at the costovertebral angle D8, D9. Again, an assessment of tumor extension was done, and the disease was again localized. Next slide, please. So a biopsy was performed and confirmed the recurrence of alveolar rhabdomyosarcoma. Next slide, please. My last question for you would be, nowadays, if this case happened today, which strategy should be proposed at this moment? Would you do a molecular profiling of the tumor? Would you do a second-line chemotherapy? Would you do a targeted therapy according to the specific fusion of the disease? Or would you do palliative care? Okay, I'm glad to see nobody would do palliative care now. We have other options for the patient. But there are positive answers. So the first thing to do would be molecular profiling, and then begin second-line chemotherapy. Next slide, please. Molecular profiling can be an opportunity to switch to a target therapy in case of new relapse. It's to have a bit time before the next relapse if it happens. At this time, this program was not ready, but nowadays it is currently proposed for patients with relapsing disease as part of European pediatric precision medicine programs. So we didn't do that, but we performed a second-line chemotherapy. Next slide, please. And the current protocol at this time was the VIT protocol. This protocol used to randomize whether in arm A, vincristine and irinotecan, or in arm B, the adjunction of temozolomide to vincristine and irinotecan. And she was randomized in the experimental arm. She received 8 cycles of chemotherapy. Next slide, please. Again, we performed a local treatment with surgical resection with removal of the tumor, and at this time, the resection was complete with negative margins. Next slide, please. We completed the treatment with a local treatment with radiotherapy. As you can see on the 2 pictures, again, I show the radiotherapy areas, and in red is the most important dose. And the end of treatment was December 2015. Next slide, please. Today we are at more of a 5 years remission, so she's almost cured. Unfortunately, she has a long-term sequel, as you can see on the X-ray. She has a radiotherapy sequel, an important scoliosis requiring orthopedic treatment. As a reminder, I show you the radiotherapy area, and you can better understand why the scoliosis is happening. Next slide, please. So my take-home messages for this case is the importance of a complete local treatment in this disease. The importance also of a long-term follow-up because of the sequels you can induce. And finally, the interest of clinical trials and randomizations procedures. So she was included in 2 protocols and 3 times randomized. I show you a bit with the help of Hans Merks. I thanks for the slides. Next slide, please. First randomization she had was Ivedo versus IVA, and the results of this study showed no role for doxorubicin in high risk for these patients. Second randomization, next slide, please, was the maintenance or not, and as a reminder, she was randomized in the arm with maintenance therapy. And as you can see on this slide, maintenance improves survival, and it's now a standard of care. And the third randomization she was included in, the third protocol she was included in, was the VIT versus VI for a patient relapsing from their rhabdomyosarcoma. And again, she was randomized in the right arm, if I can say so, showing better results for patients randomized in the arm with temozolomide, which is nowadays the standard of care. Next slide, please. So on the picture here, you can see the summary of my success story. And I thank you for your attention.
Thank you, Morgane. It was really clear and very interesting case. So, Dr. Hans, I would like to ask you to do some comments on this case, please.
Yeah, I think can you hear me properly? Yeah, great. I think this case tells many stories. One story you just summarized, Morgane, is the European story of the past 15 years. We've done 3 randomized trials, one on naive patients, and you clearly showed that Ivedo versus IVA showed that IVA is standard of care for high-risk patients, and that's half of rhabdomyosarcoma patients. So that's an important lesson learned. If you would show the picture of, if you could show the picture of the IVA versus Ivedo regimen, if you would compare survival of that randomized trial, you would have you could learn that prognosis in current days improved with 10 to 15%. So if you would have just done a cohort study, just testing Ivedo, and you would compare with a cohort of 10 years ago, you would say that Ivedo would do better than with IVA alone. But by doing it in a randomized session, you show that, okay, survival improved, probably because imaging improved, supportive care improved, local therapy improved, but it's not because of the doxorubicin. So it's good we got rid of doxorubicin for the high-risk patients, and we clearly showed that that IVA is standard of care for the high-risk patients. So that was lesson one. The second thing is that we introduced a maintenance chemotherapy, which we, in solid tumor treatment, we're not familiar with. It's more something from the leukemia world. I just discussed with the whole Peters about this. So we introduced a way of treating, the way we treat, we're used to treat leukemia patients, have been treating them for decades. We introduced that with different chemotherapy, of course, into a solid tumor after an intense chemotherapy. And this clearly improved survival by 13%. And this it's good to realize this is really a game changer in the past 2 or 3 decades. Survival improved point by point, but this really made us make a big step in treatment of high-risk rhabdomyosarcoma. And the last thing is indeed the VIT versus VI trial. We now have shown that VIT is the current gold standard for treatment of relapsed patients, improving again overall survival. The other lesson learned is that when we see such case with an alveolar rhabdomyosarcoma that relapses very soon after adequate treatment, because this patient was treated with Ivedo with half a year of maintenance, you can't think of anything more or anything more intense. Adequate local therapy, patient shows a relapse really soon. the course for these patients are really bad. So many of us would doubt whether you should start with chemotherapy. We often do, but there's clear doubt. There's an important paper written by Julia Chisholm and colleagues, published in JCO. Maybe we can share the PubMed citation. It shows that such a patient indeed has a poor prognosis because of early relapse, alveolar, adequate local treatment, having had radiotherapy, and then a very early relapse has a really bad prognosis. But this is a case that shows that it's worthwhile, I think, at least to try cure these patients. And we're now 6 years from the last relapse, so she seems safe. So this is an encouraging case, and it shows that if you do your best, do it properly, you can cure a child in such position, which obviously you lose at least 9 in 10, but we do it for the 1 in 10 if you agree with parents and the patient that this is the way to go. I think those are the most important lessons learned. Apart from of course, these late effects of it, as you mentioned, of course, a very severe late effect. I think we can't do anything to prevent it, but this is what's the reality after such intense treatment, local treatment.
Thank you.
Any questions, perhaps?
Yeah, I have a question for you, of course, as a surgeon. I would like to ask your opinion about the biopsies. Do you think that, for example, she did a surgical biopsy for the diagnosis and for genetics, and then to confirm the relapse, she did only fine needle. Do you think there is a role for fine needle biopsy at the diagnosis? Do you think it would be possible?
Yes, I do think so. So it depends on the possibilities of your own pathologist and molecular biologist. But with current analytic techniques, often with one or several fine needle biopsies or true cut biopsies, I would say, that is as good, I think, as an open biopsy. But that's a close, that should be a discussion between your local surgeon, already intervention radiologist, and your local pathologist. But often nowadays, if there's good communication, this is feasible, and it should not be always an open biopsy.
Right. In my center, we have been trying to start the fine needle, and we have good results.
Yeah.
And also, Morgane, just for curiosity, you said that after the first surgery, it was not possible to do more surgery. Was because of the patient's global state, or do you know why they didn't proceed with marker?
No, it was because the margins were very in contact of I think organs that couldn't be removed by a surgery, so it would be too difficult, so it has not been considered.
Okay.
And then again, it's a very radiosensitive tumor, so you should be able to treat it with radiotherapy. We didn't have a local relapse; it was a distant relapse. We doubted when discussing this case whether this could be a lymph node or a regional relapse. But in the end, you discussed in your team, Morgane, with all the detailed imaging, and you decided it was a distant relapse.
Yes.
Okay, so thank you, everyone. There is no questions from the audience. So I would like to thank Morgane and Dr. Hans for being here and discussing this very interesting case. And thank you, everyone from the attendants who joined, and I hope you liked it. And see you in a month.
Bye. Thank you.
Thank you, Morgane. Thank you, Sofia. Thank you all. Bye-bye.
Bye.